Welcome to the Adelphi Breast Cancer Program's STEP videos. I'm Dr. Avner Hershlag, and I'll be discussing fertility preservation for breast cancer patients. And in this presentation, I will show you why motherhood is within your reach, as well as other patients that we'll discuss. So the first patient I'd like to discuss is Natasha, who was 39 years old when she came to me, a CEO of a Fortune 500 company. 3 years ago, she was diagnosed with right breast cancer, stage 1, and had bilateral mastectomy and reconstruction, followed by chemotherapy, which was ACT, adriamycin, Cytoxan, and Taxane. She was getting married soon and wanted to have a family. At the time of diagnosis, no one discussed with her fertility and fertility preservation. And when I did her blood test, it showed that her FSH, which shows us fertility potential, was already very high at 65. AMH, which is a test for ovarian reserve, like how many eggs you have left in your body, was practically zero. And she was in menopause. The egg reserve for women without cancer is very limited, and the highest egg reserve is when you're 20 weeks in utero as a baby. Doesn't make much sense, does it? It goes down to 1.2 million when you're born, and to about 300,000 when you reach puberty, which is probably the first time that eggs can actually cause a pregnancy. And therefore, women lose their fertility potential totally when they are 50 years of age on average in the United States. Now, what happens is that chemotherapy expedites this process, unfortunately. Alkylating agents are probably the worst culprits. Second to them are the taxanes and the platinums. And for HER2-positive patients, the treatment in fact, does not decrease fertility by much. The use of Lupron, which is GnRH agonist, during chemotherapy may help preserve some of the ovarian potential. More recently, immunotherapy has been added to the cocktail that's given to breast cancer patients. The impact on ovarian function is unknown yet. The risk of premature ovarian failure, which has changed now to premature ovarian insufficiency, or POI, goes up with age. So it is fair to say that women with breast cancer who are less than 35 years of age at the time of diagnosis and treatment have still a decent chance to retain some of their ovarian function, while women over 35, closer to 40 and over 40, are very likely to go into menopause after treatment. And this is what you see, the ovarian damage as we can measure it, like on this patient that I just presented. FSH goes up and AMH goes down, and in her case, it went way down. So what I offered Natasha is egg donation. And I knew this was not a simple decision for her and for her new partner. Many times I hear patients hesitant, saying that it's not their DNA, and I totally understand it. However, with egg donation, half of the DNA does come from the couple, it comes from the husband, and you get to be pregnant and you get to deliver a baby. So this shows you the egg donation process. The egg banks are responsible for screening the donor pretty much up and down, including genetically, and for infectious disease. So that the donors that you see listed on any website of any egg bank are expected to be fully screened and ready to go. Then you choose the donor according to your specifications and your partners. And then these eggs are shipped to your fertility practice, where we keep them frozen, and then we thaw them out when the time comes that you want to get pregnant. Sperm from your partner is injected into the egg. We make embryos. The embryos grow in the lab usually until day 5 or 6 after fertilization. If you wish so, we can test the embryos for genetics, either for chromosomes to make sure that the chromosome number is normal, or also if there is a gene to be concerned about, and then an embryo that is normal by chromosomes and normal by not having the gene of concern can be transferred to you. Alternatively, you can just choose to transfer the embryo coming from a young donor without having any tests and get pregnant at a very high rate, which I'm going to show you. So this is the breakdown, according to ages, of pregnancy from donor eggs. And what you can see here is that because the donors are young, the typical age of egg donors is between 21 and 32. The pregnancy rate or even live birth rate is consistently high. In fact, it ranges between 50 to 55%, and that is for a single embryo. Let me stress this again. A single embryo transferred, whether you are less than 35 or over 43, the pregnancy rate is the same, and over 50% of the patients are expected to get pregnant. And that is just from one embryo, meaning that if you have several embryos, and let's say, God forbid, you did not get pregnant the first time around, your chances are the same with the next transfer, which makes the pregnancy rate for 2 embryos about 75%. Now, this graphic shows you the decline in fertility as you go with your own eggs, and that's the blue line, versus anything else that is done with donor gametes. And that's the upper lines. They're all in different colors, and they include donor eggs, they include donor embryos, and the pregnancy rate, as you can see, is a straight line at around 50%. So you may be able to have more than one child. And remember that the eggs, as long as they're frozen, are staying at the same age that they were frozen at. So for example, let's say you have a 28-year-old donor, and you made one embryo, you got pregnant, and now you have a child, and you have more eggs in the freezer. It's actually not the freezer. It's not like next to the meat in your freezer at home. We're talking about liquid nitrogen. They are in tanks. The temperature of liquid nitrogen is almost 200, in fact, 196, below 0 centigrades. That's how low it is. And that's how we are able to keep human tissue frozen and not going through cell cycles so it doesn't age. So the eggs do not age with you. So for example, if you were 40 and you got pregnant from donor eggs and you have another quote-unquote batch of eggs frozen, you can come back when you're 42, 43, and you're still a survivor, no evidence of cancer coming back, and have a second transfer and a second baby. And you can have a whole family this way. If you were just diagnosed with breast cancer, you may be overwhelmed by the barrage of questions that come to your mind and that you feel are not completely answered. I'll try to relate to each one of them. First one is the C word. So scary to be told that you have cancer. But breast cancer statistics these days are so good, with survival of over 90% of patients. So likelihood is very, very high that you will survive your disease. The second thing that comes up is the surgery that you might need to have. And in many cases, it's recommended to have mastectomy. There is no question that having breast surgery is challenging and emotionally taxing. However, reconstruction options are open to you, And there are many advances in plastic surgery, should you choose to go that way, that are extremely successful, and patients are very pleased. When you discuss chemotherapy with your oncologist, they will go through all the side effects that sometimes seem scary. When breast cancer patients come to me, I connect them, if they're not already, with wig makers so that they can plan their wig during the time that they lose their hair. And it comes back, and it comes back in a very good way for all patients. Then comes the question of relationship and intimacy. Will my partner stick with me? The good news is that I see patients years after they first came to me with a diagnosis, and most of them are with their partners and planning a family. If you are single at the time of diagnosis, there is that concern that, will you ever get a partner now that you have been diagnosed with cancer? And the news here is also very positive, because patients who have frozen their eggs when they were young and had a breast cancer diagnosis typically come back to me with a partner, and we start making babies for them. And then comes the fertility concern, which I consider to be the silver lining, and that is because fertility represents hope and the fact that we assume that you will survive your cancer and that you will use frozen eggs, frozen embryos, or conceive on your own, and that you have an open future ahead of you. Jessica was a 27-year-old who came to me with 5-centimeter breast cancer and was receptor positive for estrogen, progesterone, but not for HER2. Her partner for 4 years was 28 years old. She had a rich history in the family and a mother who had breast cancer young, but she was negative for the BRCA genes. So she was asking, why should I have fertility preservation? I'm young, and we just showed you that young women, many of them do get their ovarian function back after chemo is done. But the statistics shows that if you did not preserve your fertility, you do have a chance to get pregnant, but probably at around, let's say, round it up to 20%. While women who have fertility preservation, their pregnancy rate is rounded up to 41%. And in fact, I think the numbers recently are higher and may reach over 50%. There was a Swedish study that was critical because we wanted to know how safe is fertility preservation. And they had a very large group of patients, close to 6,000, and they showed that there was no increased risk of relapse, of recurrence of breast cancer because you're doing fertility preservation and IVF prior to treatment. And this is the typical cycle. What we do in terms of stimulation, the patients are concerned, if my estrogen goes up during an IVF cycle, knowing that my breast cancer is estrogen receptor sensitive or positive, will this make my breast cancer worse? And the answer is no, according to everything we know at this point. But we help by giving you a different protocol. We add this medication called letrozole. Letrozole lowers estrogen. And because it lowers the estrogen, the levels of estrogen that I see in an IVF cycle on a breast cancer patient is significantly lower than what you see in stimulation without letrozole, and is closer to what you have in your normal menstrual cycle. Also, it is advisable to continue the letrozole after the egg retrieval is done so that the estrogen level in the blood goes down faster. And this is the procedure where we actually, as you can see on top, You have a uterus full of follicles. On the right is the way it looks like by ultrasound. We retrieve all these eggs, and then we perform fertilization if you have a partner. On the right, it could be by ICSI, which is injection of sperm into the eggs. Or if sperm is completely normal, we don't even need to do that. We just place sperm on top of the eggs. It's called insemination. And on the left, you see an egg that is frozen as an egg. And this is the freezing process. You may hear a different term now. It's called vitrification. It is actually a more recent development, not that recent anymore, of the way we freeze eggs, and much more successful than it used to be before, with a very high survival rate. And this is the dilemma, eggs or embryos. This dilemma we see in all patients who do have a partner. What is better, doctor? Should I freeze my eggs, or should I fertilize them and freeze embryos? Well, the answer is not so black and white, but I'll show you this statistic, and this was done in Europe from Dr. Ana Cobo from Spain. Show us very clearly that whether you use donor eggs as fresh eggs that you just retrieved from the donor, or as donor eggs that were frozen and you thaw them out or vitrified them, the end result is the same, with a very high live birth rate of 55% on either column, which makes us very comfortable using frozen eggs. So, yes, you can go at it alone, and you can go at it as a couple. The difference is not the pregnancy rate, but the level of freedom. With egg freezing, you are the only one who controls the fate of these eggs. If you are single, there's no other way. But even if you are in a couple situation, I've advised some of my patients to actually consider, if they had a lot of eggs, to split them between embryos and eggs, so that, yes, the embryos are committed. There is a male and there is a female involved. But the eggs, just in case in the future you would want to make your own decisions, the eggs are just your property, and for you to decide what to do with them. So Jessica started gonadotropins, the fertility drugs, and letrozole. We got 13 eggs, and she went on to do chemo before surgery and reconstruction of her breast. Women diagnosed with breast cancer are still able to multitask and move on with their life, while men have a problem dealing with more minor issues. But I want to give 2 thumbs up for my heroine patients. Thank you for watching part 1 of this presentation. Stay tuned. Part 2 is coming up next.